software is not going with you cannot you can make everything good in your dossier. But if the system doesn't work,
so it's a problem of putting all the eggs in one basket, or whether have competition, and there is always a trade-off. One is not good, but the other is not good either. So there should be some sort of middle way.
If your software loses the certification, then you have to buy a new one, or what? How's that?
Yes, but then it's the problem that all my data were inside. If I can get them, or if I lose them and I had to put it in.
But isn't it possible to transfer? I mean, in Austria we have a very similar situation. It's all kind of software vendors, and but there's a law that they have to be compatible in terms of that data can be transferred.
The latest criteria of the certification, that is one of the biggest criteria. But when my system doesn't do it, I cannot change.
One of the things that we've struggled with in the States, we have more than 200 electronic health record vendors. And so it's like a Tower of Babel. And so most all of them will meet HL7 standards, Health Language 7th version. But for the clinician, that's not good enough. In other words, what HL7 will allow you to do is you can take a laboratory value and you can transmit a text piece of text data that says that the potassium was 6.1 or whatever it was. Well, what you need as a clinician is actually a number that you can put into a field and have it modified and manipulated. Sure. Yeah. And so you can get the information from the other records, but it doesn't really help you. It's because then you have to somehow go back into notes and find it. That's just not
so it must be. Here are some examples of the meaningful use. Stage 1 requirements, which are already in place in the US, and in blue in the middle you can see some features which are actually related to decision support. And at the next stage there will be many other rules. And at the same time there are also quality measures that have to be reported directly from the EHRs, and they can also be in the form of decision support rules also. So here are some of the rules from the first set, the quality measures, and here are just some examples of the next set, which will be valid from 2012 to 2013, and there are 36 measures altogether, of which you can choose which you will be able to report. And you see that there is, for instance, appropriate use of imaging studies for low pain, so that's for reducing waste, not to take too many X-rays for patients with self-limiting conditions and things like that. Then in the UK you have the cough measures. You heard yesterday the plenary lecture about them. Data is recorded automatically, and there are reminders for providers, and for this patient there is no cholesterol value from the last 15 months, so you should order a cholesterol test. But what's the adverse effect? I have interviewed some British physicians, and they are very reluctant to use any other decision support rules than those for which they are paid for. So maybe the right thing would have been to first introduce decision support and then select some rules also which you are paid for. If you first make the pay for performance system and then develop decision support rules to support that, so then maybe you are not resistant to other types of decision support.
Can I ask you, how did you finance the development of this? Who financed the development of this?
For our system, well, we got some national support for the technology fund of Finland. The guidelines are supported by the Ministry of Health, but then it's our publishing company, which is 100% owned by the Medical Society, so it's a non-profit company. We produce the National Health Portal, we produce the National citizens' health portal, and we actually sell subscriptions for those. Every health center, every hospital district has bought a subscription, so actually we have our own income, and on the basis of that income we develop this disease support service, which we then also sell to the users. So it's not free of charge.
If I were in a single-handed practice, one doctor, what would that subscription cost me in a year?
It's actually in Finland, practically every doctor is salaried, so that it's the employer of the doctor who will pay, but it's a few tens of euros per year. So it's about 1/10 of the sum that a typical US physician pays for his or her solutions. So actually the price level is much lower in Finland and in Europe. So it's less than $100 per year, which you have to pay for one doctor for the disease support application device.
You know, that's interesting because one of the commercial services that a lot of doctors use is Hippocrates, which is mostly medication, so it's got some other things, and you can easily spend $300 or $400 US per year. But it's nice, you put it on your handheld, you know, you make decisions at the point of care. So it sounds like you've got a very good price.
Yeah.
Did you do, or is there research on how it works on decisions and also on what is the influence of the consultation?
Yeah.
I'm wondering. Well, I'm sitting in my room and I have a patient and I have my computer and I have a lot of data and then I get reminders. How does it work? How does it influence the quality of my consultation?
We are doing research all the time. In the first place, qualitative research, but now also quantitative research and even a randomized control trial of the effect of this. So we are collecting this data, but I do not have the data yet from the trial. And we are actually starting many more trials. So we will also compare different ways of giving the reminders in the future. And we try to do research all the time, and actually the outcome measure is the virtual health check. So we perform the virtual health check every month, and then we can see whether the quality measures change. So actually this system can also be used for outcome recording. For recording the outcomes.
Yeah, then you only measure on our quality outcomes. So is there, well, maybe that's the unmeasurable, but is there, did you specifically look at how it influences my communication with the patient and the satisfaction of and the trust of the patient in me when I'm constantly looking at my screen, or that's the how
you must have looked at the slides for my talk tomorrow. That is the point.
We are aiming at wonderful figures,
I think we should have decision aids which we could look together with the patient. That would be one solution. Not that the doctor is looking at the screen and not to the patient, but we look at the screen together if we have to look at the screen.
Both is important, I guess.
Yeah, I think so. Yeah. There are some doctors who have two screens, one for the patient and one for himself, so that the patient can see all the time.
They don't have to talk anymore.
Actually, the Ariba tool that I mentioned this morning is exactly this, and it has a lot more to it. I only showed the risk calculator, but behind it there are more pages where you make with the patient decisions about interventions like statins or antihypertensive treatment and what kind of risk reduction you can achieve with that. I use it all the time in my practice, and I just flip the screen over and we look both at it. So, but I think that is the future that we will need to communicate risk and benefit with the patient and then come to a shared decision.
I think that it's difficult because we have to work on different level of communication in the same time.
Yes.
We communicate with the computer and the data, and we have someone in front of us
and we have to change, and we have to improve our ability to
Work the
go
system.
on a level and change in 1 second, come back,
Yeah.
and maybe we can share with the patient, but sometimes not, because the patient is not in the it's not possible for him to understand, maybe he doesn't want to think on this level. He said,
He maybe want you to make the decision and
Yes.
not to do this. I mean, but I think that this is also a question like you infer that this must be a question of skills.
yes.
How do you learn this, and how are the system developed? How easy are they to manage? And how have you actually learned how to manage them in this situation with the patient?
So probably we should adjust also our education on this.
Yes,
And
exactly.
change
On
communication skills.
On patient communication, education, how to interact with it, with the different types of patients, because you will have young patients who will lack confidence in you if you can't give them some, if they have the feeling that you're not up to date and you think that you know it all. And you will have older people, you have other types of patients who will lack confidence in you if you actually don't pretend to know it all and give them a fast answer. So I don't think it's like any other social interaction. It's changing over time.
Yeah, so it's a social interaction, but also we have to teach them how to flip from the rational information from the computer to the personal information in the different phases of one consultation.
So I've been working in the electronic health record environment for about 15 years, a couple of different systems, vendors. I wrote actually in the Finnish Medical Journal last year, the year before, on what I call the third person in the room, which is the computer. And there's an etiquette. There's an etiquette to working with the computer. If a patient comes into our practice that's never been in a practice with a computer before, I introduce the patient to the computer. Here's the computer. And it's little things like when you start with a trainee, you say to them, just sit down and look at the patient and begin your conversation. Don't look at the computer at first. Begin the conversation. And then when you reach that point where you say, oh, I need to put some information in, turn the screen so the patient can see it as you're putting the data in. And then ask them to confirm, did I have this right? You know, I pull up tables all the time, I pull up decision support tools all the time. Actually, patients, even young and old, they like it very much because they see you as more sophisticated, better informed. But your point's very important. You have the language that we use has to be different. You can't use the sort of technical language of, you know, positive predictive value. You have to communicate it then in a way that makes sense. That's the challenge.
And that's the skills that people who have done it for a long time have to learn, or have to teach individuals.
It's hard. It's hard to learn.
And also, doctors think that when they start to use a computer, that should go straight away. If they start doing some laparoscopy surgery, so they have to train for a long time.
Yes,
Yeah.
yes.
So, but people think that computers is something you learn to use in 1 minute. It isn't.
No. And it's like a tool, but I think I have in my practice a tool and I don't know how to use really this tool.
Yeah, that's what we say. They have a Cadillac, but they use it as if it was a bicycle.
We say they would
We call it an expensive transcription machine because you just take the notes that you used to type on paper, and that's all you're using the computer for. You're not using all the functionality.
But there are things in it, I think, that patient can be not so satisfied with you if they feel that you concentrate too much on the screen.
Yes, of course. And well, that's the challenge, I guess,
Yeah,
to
it's
learn to work with the tool.